Soldiers and other military members with post-deployment respiratory symptoms. We started looking at this problem back in 2010 when we first were made aware of some research that was being done by several civilian organizations or civilian hospitals, looking at the types of pulmonary disease that they were finding in the group of patients that they evaluated. In the military, at least those of us who were pulmonologists in the military were not aware of the research going on, and we weren't seeing the same type of patients. We weren't seeing the same types of diseases that the other people were reporting, so we decided that, well, we need to set up a program to really take a comprehensive look at this. We didn't agree with what they were saying, and we thought that there was probably other things that were involved in with these patients. Through the Medical Research and Material Command, which has one of its offices is the Center for Environmental Health Research. We got some money from them, and we started a number of programs to start prospectively looking at the issues involved. So, the first one we did, which we nicknamed or called Stampede, is the study of active duty military for, I can't even remember, environmental dust exposures, active military personnel for environmental dust exposures. That was our first, one of the first things we did, and we took 50 soldiers, mainly from Fort Hood, that had acute symptoms within 6 months of redeploying or had developed symptoms while they were deployed. And we put them through a series of tests and looked at them and found that there was a lot of asthma, a lot of airway hyperreactivity, which you would expect given the population as a whole. About 40% of them, we really didn't have a specific etiology that we could diagnose. And so we felt that the previous reports had described some very, very rare lung diseases that we didn't find in our cohort at all. And so we felt that that there was a bigger variety of diseases out there. The next study that we did was called, well, we called it Stampede 2. We're in the process of writing that one up, but there was a question of whether or not we should do breathing tests before all of our personnel deploy, and whether will that pick up disease earlier than just asking them questions when they come back. And so we did this at Fort Hood as well, and we looked at 1,700 individuals, and we got breathing tests on them before and after they went. And interestingly enough, a couple things out of that the force as a whole that we're deploying is much older, is not as healthy as you would think. A lot of people with asthma who deployed, a lot of smokers, and many of them, because it's not all active duty, it's Guard, Reserve, other people, weren't in the best physical shape, and so they're going over deployed. When not as cardiovascular fit as you would expect. They're bigger, they have a higher body mass index, and so there may be more symptoms given the exposures over there, the dust, the burn pits, other specific exposures that they've seen. So we looked at them, and we're writing a paper right now on just what their baseline characteristics are. And then we finished up the study a couple of months ago, and we're now looking at the breathing tests that we did, and we found that actually, as a whole, as a group, we're not finding any specific trend towards worsening breathing tests. And we don't think breathing tests in and of themselves are a good screen, and we've looked at the cost involved, and the cost involved in doing the whole force is tremendously high. We've also done another study here with the soldiers that come through for their advanced individual training. and found, we've done 900 of them, and found that their smoking history, their asthma history, their symptom history doesn't really correlate very well with the PFTs. So we found a lot of people with abnormal PFTs, a single PFT or single spirometry, that really doesn't mean anything. And that's one of the problems with spirometry, is that if you do it as a single test and you don't do it correctly, it gives you all sorts of values that don't mean anything necessarily. You have to correlate that with what the patient's symptoms are and the history and things along those lines.